Hello and welcome back to Tuberculosis Part 3. So in Part 3 and 4, we'll be studying the individual first line oral drugs in Part 3 and the rest in Part 4. In Part 1 and 2, we've already studied what is tuberculosis and how the short course regimens have been devised. And in Part 2, we saw the prevalent patient categories and the actual treatment regimens. And now we go on to seeing the individual drugs used in these treatment regimens. So in Part 3, as I said, we would study the first line oral drugs, INH, Rifampicin, Pyrazinamide, and Ethambutol. And in Part 4, the injectable first line, injection Streptomycin, and groups 2, 3, and 4. From these groups, the ones which are being actually used in these RNTCP regimens will be studied. Before going on to the individual drugs, let's see where all these drugs work. What are the targets of attack in the mycobacteria? So mycobacteria have a lipid-rich cell wall, the outermost layer being made up of mycolic acids and polypeptides. The middle layer is made up of arabinogalactan, and the innermost is the peptidoglycan layer. Of course, there are intracellular organelles and mechanisms like DNA being transcripted to messenger RNA, copied down onto the messenger RNA, and then this copied recipe being actually translated to the manufacture of proteins in the form of proteins. So all these are the mechanisms which are happening inside, plus metabolic processes like folate metabolism and so on. So majority of the drugs, they are working against or interfering with the synthesis of mycolic acid. So INH and ethionamide as well as pyrazinamide interfere with the synthesis of mycolic acids, the important components of the bacterial cell wall. However, INH ethionamide on one side and pyrazinamide on the other, they interact with different proteins for interfering with the mycolic acid synthesis. So there is some distinction in the mechanism of action. Plus, we've seen that pyrazinamide is effective in more in acidic medium, and that's its major role. And pyrazinamide, apart from interfering with mycolic acid synthesis, also damages the cell membrane. That's another peculiarity of pyrazinamide. Ethambutol interferes with the synthesis of the middle layer, that is arabinogalactan layer, whereas cycloserine interferes with the cross-linking in the peptidoglycan layer. Streptomycin, the first drug introduced against tuberculosis, interferes with the translation of messenger RNA into proteins, that is protein synthesis by interacting with the ribosomes. But again, the proteins affected finally affect the cell membrane integrity. So despite being a drug with primarily effect against protein synthesis, the effect is always cidal of the entire aminoglycoside group, as we've seen. Rifampicin, the other key drug for tuberculosis, it interferes with the transcription of the DNA code onto the messenger RNA. So that is the major mechanism of rifampicin, by preventing or inhibiting DNA-dependent RNA polymerase. And fluoroquinolones, they damage the DNA themselves by interfering with the action of DNA gyrase, which is important for keeping the DNA intact in spite of participating in its functions of DNA replication or RNA synthesis. So these are the various targets in the mycobacterial cells which are attacked, or where these different drugs attack. And you can see that we combine drugs having different mechanisms, which gives us a more synergistic effect and less chance of cross resistance between them, because their targets are different, and usually the targets are being modified for development of resistance, one of the common mechanisms of development of resistance. So now let's go on to the individual first line oral drugs, INH, rifampicin, pyrazinamide, and ethambutol. Whether these drugs or subsequent drugs in part 4, we would usually be talking about their mechanism of action and effect and role in tuberculosis, management of tuberculosis, mechanism of resistance and ways to overcome it, adverse drug reactions and precautions or solutions to minimize them, and the current status in management of tuberculosis. So INH, or isoniazid, is represented by the letter H because of the other name INH. It's the cheapest and most important effective anti-TB drug along with rifampicin. So rifampicin and INH are the two key drugs in management of tuberculosis. The effect is bactericidal and it is able to kill bacilli in the extracellularly existing bacilli in the walls of the caseous lesions, also those inside the macrophages. So it is able to enter the macrophages and work there as well. And because it tackles bacteria at both these places, it contributes significantly to rapid reduction in the total number of bacilli, giving rapid sputum negativity and rapid control in the transmission, because we saw transmission is through droplet infection, which is spread from the sputum of the infected individual. It also, like any drug in the combination, reduces or inhibits the development of resistance to other drugs of the combination and does not show cross resistance with any of them. The mechanism for INH in details. INH is actually a prodrug which is actively taken up by the bacteria, and the bacterial enzyme, catalase peroxidase enzyme, which is present in the bacteria, is capable of activating INH into reactive metabolites. These reactive metabolites are therefore formed only inside the bacteria, not in the human cells. And these reactive metabolites can interact and form an adduct with NAD as well as with NADPH. And the adduct formed with NAD can bind with and interfere the action of two proteins important in manufacturing of mycolic acid, INHA and Cas-A. Both these proteins are required in the manufacturing process of mycolic acid. So by binding with these, interfering with their action, mycolic acid synthesis is interfered, so the proper cell wall will not be formed. The reactive metabolite, as we discussed, can also bind with NADPH, and this adduct, this binding with NADPH, interferes with the dihydrofolate reductase enzyme activity, which is required for folate metabolism. And because folic acid is required in DNA synthesis, this interference will compromise the DNA synthesis process. So INH is converted into a reactive metabolite, which can ultimately either or both affect mycolic acid synthesis as well as DNA synthesis. But as we saw, resistance has already started developing. So what is the mechanism of development of resistance to INH? We saw that 1 in 10 raised to 6, that is 1 in 10 lakhs of tubercle bacilli, could be inherently resistant to INH. And the mechanism of this resistance is that the enzyme coding for the activating enzyme, catalase peroxidase enzyme, that undergoes mutation, so that proper enzyme required to activate INH, to convert INH into the reactive metabolite, is not available. So the reactive metabolite will not be formed. Other mechanism of resistance is the genes which code for synthesis of INHA and Cas-A. The INHA gene and the Cas-A gene, they undergo mutation. And the effect of this mutation is increased production of these target proteins. So if the gene mutates, more of INHA is produced. The difference in knowing, or the purpose or advantage of knowing what is the method of resistance in this particular patient, is that if the resistance is due to CAT gene mutation, where activation of INH itself does not occur, we can't do anything about this resistance. But if the resistance is due to overproduction of INHA protein, then we can counter it by increasing the dose of INH. So if we increase the dose to 3 times, that means instead of 300 milligrams per day, if we give 900 milligrams per day of INH, we can overcome resistance due to overproduction of INHA. Another method of resistance is developing a mechanism to actively throw out INH which has entered the cell, and lastly, the active uptake itself is reduced. So these are the 4 mechanisms for development of resistance against INH: either mutation of CAT-G gene, which reduces the activation of INH, which we is a resistant mechanism which cannot be overcome. Second is to a mutation which increases the production of target proteins, which could be overcome by increasing the dose of INH. And third and fourth mechanisms are throwing it out actively or not allowing it to come inside the bacterial cell. So in short, INH is actively taken up by the bacteria, activated by a mycobacterial enzyme, not a human enzyme. This reactive intermediate forms an adduct with NAD, which will interfere with the action of the two important critical proteins involved in mycolic acid synthesis and thereby interfere with the cell wall synthesis. And an improper cell wall increases the susceptibility of the bacilli to oxidative damage and results in sidle effect. The adduct with NADPH can interfere with the synthesis of DNA. And we also saw the mechanisms of resistance. Inherently resistant bacteria could be 1 in 10 lakh. Rapid development, the others would be sensitive ones would be killed, and this one resistant bacterium can replicate. So there's rapid emergence of resistance if used alone. And the mechanisms are reduced activation, increased production of the target molecules, reduced active uptake, or ability to throw out INH. And we saw that excessive production of INHA can be overcome by increasing the dose of INH by 3 times. So 900 milligrams instead of 300 milligrams of INH per day. INH shows good oral absorption and distribution and also very good CSF levels. So it is useful for TB meningitis. It shows a peculiar variety of slow and fast acetylators. So genetic polymorphism. 70% of Indians are slow acetylators of INH and 30% of Indians are fast acetylators of INH. What is the clinical relevance of this? INH itself can cause neuropathy. In slow acetylators, INH stays for a longer time, and therefore these slow acetylators are at a greater risk of peripheral neuropathy. The acetylated metabolite is hepatotoxic. Fast acetylators convert INH to its metabolite 4 times faster. So INH levels will go down rapidly, but the hepatotoxic metabolite will be formed very rapidly and give high levels. So the fast acetylators are at a greater risk of hepatotoxicity because of the metabolite. Another clinical implication is, if you've heard, in between we had DOTS regimen, where these drugs could be given only thrice a week. But this probably did not work in the fast acetylators, which destroy INH 4 times faster, and could have been one of the reasons why DOTS could lead to emergence of resistance. And today, we no longer use thrice a week regimen for tuberculosis. The hepatotoxicity produced by the acetylated metabolite is dose dependent and reversible. And actually, hepatotoxicity is one of the common adverse effects of many of these anti-TB drugs. Therefore, liver function test is assessed before starting the treatment and periodically in case of prolonged treatment. Neuropathy because of INH is because it interferes with the activation and utilization of pyridoxine. Because it is not activated, it is also excreted fast. And therefore, we can prevent or treat neuropathy by giving pyridoxine. The preventive dose is 10 milligrams per day, whereas therapeutic dose of pyridoxine is 100 milligrams per day. So pyridoxine to prevent or treat neuropathy, and because most drugs are hepatotoxic, we need to monitor liver function before starting the drugs and also periodically in case prolonged treatment is required. Another important adverse effect of INH is gastritis, gastric irritation, acidity, and therefore patients may be tempted to take INH along with antacids. But all the antacid formulations available today have aluminum hydroxide and magnesium hydroxide. And aluminum hydroxide can interact with INH and reduce its absorption. So patients have to be guided that they should not take it along with antacids. INH is an enzyme inhibitor, and it inhibits the enzymes which are also required for warfarin and phenytoin, drugs which have critical narrow margin of safety or specific effect is required. So if more of warfarin is available, more of phenytoin is available than should be, it will lead to toxicity of these drugs. And toxicity of warfarin is spontaneous bleeding. Coming to rifampicin, unlike INH, which is useful only for tuberculosis, rifampicin has a wider spectrum. It is also a key drug for Mycobacterium leprae. So leprosy management, brucellosis, atypical mycoplasma, and Legionnaires' pneumonia, and so on. Effect in tuberculosis is bactericidal, and it kills extracellular as well as intracellular bacilli. And importantly, we saw that it is the only drug amongst these first-line agents which can kill the spurters or persisters. And this is what has enabled us to reduce the duration of treatment, because these persisters, which start replicating slowly at a later time, can result in relapse. So early maximum cell kill is possible and rapid sterilizing action is possible because it has action on these three subpopulations of the tubercle bacilli. So we get rapid sputum negativity, rapid control in transmission, and like any other drug in the combination, it also reduces development of resistance to the other components of the drug regimen. So it is the key drug which has enabled shortening the course of the tuberculosis treatment regimen. Mechanism of action of rifampicin is that it inhibits the bacterial DNA-dependent RNA polymerase, the enzyme required for transcription, that is, production of messenger RNA from the DNA code. So it interferes with messenger RNA production, and messenger RNA is required for the gene expression, actual production of the protein. So it interferes with the bacterial gene expression. And the effect is bactericidal. It is relatively safe and non-toxic to humans because it has less affinity for the human RNA polymerase. The parallel enzyme in the human cells is not interfered with, but the bacterial DNA-dependent RNA polymerase is inhibited. We do have 1 in 100 lakh bacteria, which could be tubercle bacilli resistant to rifampicin, and therefore single drug use would lead to rapid emergence of resistance. The mechanism of resistance is altered target enzyme. The DNA-dependent RNA polymerase enzyme is altered by mutation in the gene which codes for this enzyme, and therefore the drug cannot bind with it. There is no cross resistance with other anti-TB drugs, first-line drugs. It is also well absorbed, better absorbed on empty stomach. So that is one instruction to be given to the patient. Well distributed with good levels in CSF. So both INH and rifampicin are important for management of TB meningitis. The difference from INH is that INH was an enzyme inhibitor causing excess levels of warfarin and its toxicity, whereas rifampicin is a very powerful enzyme inducer. It induces enzymes required by many drugs for their biotransmission, and therefore the drugs would be destroyed faster. So effect of warfarin, sulfonylurea, the anti-diabetic agents, would be reduced. Even oral contraception can fail. HIV drugs also being administered to coexistent HIV as a comorbidity, they could be rapidly destroyed and therefore their effectiveness could go down. So some of these interactions are very important to remember. For example, women of childbearing age who is diagnosed to have tuberculosis would usually be advised to avoid conception while on treatment. And the combination hormonal pills are the commonest used oral contraceptives. But we saw that because of the enzyme induction effect, these combination pills can fail. So this advice, this guidance has to be given to the lady with childbearing age who is started on anti-TB treatment. Similarly, because HIV patients receiving protease inhibitors or non-nucleotide reverse transcriptase inhibitors, if they are destroyed fast, their effect will go down. Resistance may emerge for HIV, and therefore rifabutin An analog of rifampicin with less enzyme inducer ability is usually preferred if there is coexistent HIV. As we said, it doesn't affect the human enzyme, so it's relatively well tolerated with just less than 5% incidence of adverse drug reactions. But the effect which is seen in every patient is orange-red color to all body secretions, including saliva, urine, sweat, everything, which can be very alarming to the patient. It might be confused for hemoptysis or hematuria, but it is just the color of the drug being secreted in all these body secretions. And so this has to be an important component in patient counseling. It can give rise to some problematic adverse effects like diarrhea, hepatitis, ataxia, dizziness. Flu-like syndrome is seen at high doses, and as we discussed, it is otherwise avoided in pregnancy except in tuberculosis. So tuberculosis during pregnancy does include rifampicin as a treatment regimen, but for any other infection and any other indications we talked about, rifampicin would be avoided if the patient is a pregnant lady. So the indications of rifampicin, apart from tuberculosis, where it is a key drug, which has enabled shortening the duration, and we have seen what are the advantages of a shorter duration, of course. It is also the key drug for leprosy, brucellosis, staphylococcus septicemia, Legionnaires pneumonia, and it is the important prophylactic agent for meningitis during epidemics. So rifampicin does have other indications apart from tuberculosis. Coming to pyrazinamide, its effect in tuberculosis is again bactericidal, and it is effective even inside the macrophages. And it is the most effective drug amongst the first line drugs in acidic environment, which is encountered in the newly infected inflamed sites. This is the more important contribution of pyrazinamide, and therefore it plays an important role in initial intensive phase, giving us quick sterilizing action. It also contributed immensely to reducing the duration of treatment. Introduction of rifampicin reduced the duration to 9 months from 24 months, and 9 to 6 months was possible when rifampicin and pyrazinamide both were used together. Mechanism of action, we discussed, it also inhibits in the synthesis of mycolic acid. It is also converted into an active metabolite called pyrazinoic acid, which would further bind with an important protein involved and reduce the synthesis of mycolic acid. The protein it binds with is different from the one with which INH or ethionamide bind. The other important action of pyrazinoic acid is also disrupting cell membrane integrity. So it's working by two mechanisms. Resistance does develop to pyrazinamide also, and it is by non-availability of the enzyme required for production of the active metabolite. The PNCA gene gets mutated, and the enzyme required for activation is not available, and therefore there is resistance to pyrazinamide. It also shows good oral absorption and good distribution, giving CSF levels equivalent to the plasma levels. So another important drug for TB meningitis. Adverse effects are metallic taste, GI disturbance, photosensitivity, hepatotoxicity. The peculiar adverse effect is it interferes with the excretion of uric acid, and accumulation of uric acid can lead to gout and arthralgia. These are typical adverse effects of pyrazinamide. Ethambutol, which is effective against bacilli resistant to INH, streptomycin, and ethionamide. Though itself it is bacteriostatic, but it is effective, it exerts its bacteriostatic action against bacilli which are not being killed by INH, streptomycin, or ethionamide. And it is mainly acting against rapidly dividing bacteria. It does enter the cells, but also effective in extracellular bacteria. There is no cross resistance with other drugs, and its important role in the combination treatment is to prevent emergence of resistance and tackle the bacilli resistant to the other first line drugs. Mechanism of action, it inhibits arabinosyl transferase enzyme required for arabinogalactan synthesis, and arabinogalactan is an important component of the middle layer of the cell wall, so that is being affected. And as we already mentioned, this arabinogalactan layer is the one which importantly enables the bacteria to survive even inside the macrophages. So this arabinogalactan layer synthesis is interfered with by ethambutol. Resistance is slow to emerge, and the mechanism is altered target enzyme arabinosyl transferase by emergent mutation of the gene responsible for coding this enzyme. Ethambutol is well tolerated, and the typical or peculiar adverse effect of ethambutol is reduced visual acuity and color blindness, where appreciation of green color is affected. That's the typical adverse effect of ethambutol. It can also lead to retrobulbar neuritis, which is a dose and duration dependent and reversible adverse effect. So again, ophthalmic checkup. Initially, ethambutol was used only in the first 2 months of the intensive phase. Intensive phase itself was 2 months, and ethambutol was only used there. And usually, this adverse effect doesn't occur within 2 months. But now we know that ethambutol is continued into the continuation phase, and therefore, patient would be told to report any problem in vision and appropriate checkup, and if would be done, and if the adverse effect manifests, then we may be forced to change to another drug. So that is the peculiar adverse effect of ethambutol. Visual acuity is interfered with and color blindness may occur. That completes the 4 oral drugs used as first line agents in management of tuberculosis. Happy learning. Thank you. We'll come back with part 4, where we'll be talking about the details of the rest of the drugs which are being used in these treatment regimens.